But what you see, what you're looking at, is pretty much the same thing for any postpartum patient. You're doing your bubble curve. You're doing a head-to-toe assessment. But thank goodness, on every patient, you don't find ecchymosis. Not every lady is unlucky enough to have hemorrhoids. We seldom get some signs of shock, but we could. Those surgical patients still have distended abdomens, sometimes they have an ileus. A lot of people have problems with voiding post-delivery. You figure how close the urethra is to the vagina, and a baby has come through that space, or if she's post-op section, she's had a catheter in, an indwelling catheter. And sometimes it's really hard for her to be able to void afterwards. So these are some of the things that you see with when you go to assess a patient. Nothing new and strange here, right? On med-surg, you didn't have people with nipple damage, engorgement, red streaks, lumps, and spot ducts. And for the most part, in the hospital, you don't see much of that either, because those problems develop after they leave, and with going home in 24 to 48 hours, you're not going to see that much of it. But we'll talk about it in just a little bit. We know that home ensign is not evidence-based, and in some facilities, we still do it. But we know that you can have a thrombophlebitis and have a negative home ensign, or you can have a positive home ensign and there's nothing wrong. Then we have a wide variety on how much activity postpartum patients are able to tolerate, and a wide variety of reactions to a new baby that we see in terms of bonding and attachment behaviors. We're basically going to go complication through complication and talk about them. We already talked about one of the reasons for postpartum hemorrhage, which was that precipitous delivery. And just for a moment, looking at a worldview of OB, we are incredibly blessed here to have the emergency systems that we have in place to be able to take care of patients that do have complications. There was an article that was in the Washington Post, and it's only been a couple of years ago. But each year, 500,000 women die in childbirth worldwide, about one every minute, which is a really, really big number. In the United States, the chance of dying in childbirth is 1 in 48,000. This is not a test thing, I'm just talking to you for a couple minutes. In Ireland, it's 1 in 4,800. Okay, so 4,800, 48,000. What do you think the difference is between Ireland and here? Pardon? Okay. Very good. I'm not real sure that affects childbirth. Anybody else have an idea?
More women want to do C-sections here?
More women delivered by C-section here? Oh, absolutely. Okay. Here versus there? No, let's look at the other way around though.
Prevention.
Did I get
Prenatal care.
Starting over, do over. In this country, 1 out of every 4,800 women dies in childbirth. In Ireland, it's 1 in every 48,000.
Oh,
okay. And in Sierra Leone, it's 1 out of every 8. So the difference between Ireland and here, let's start with that one first. National health, okay, so there is prenatal care for everybody, no if, ands, or buts. What else?
More home births?
Oh, yeah. Who has most of the births? More midwives, absolutely. So there's less intervention, there's more, quote, natural approach to childcare. But you're also working with a different population. Go for it. I didn't say it, you say it. Oh. So we have a lot of older women having babies here, 40 and older, because we have a lot of infertility treatment. And if you're looking at a population, it's a young population, late teens in their 20s having babies. They generally are a much lower risk population. They haven't had a chance to develop a lot of the comorbidities. The United States has one of the biggest obesity rates in the country, which is a whole other discussion about childbirth and its complications. We really haven't talked about that one at all, and it's way up at the top of the list in terms of adding to complications. This was some pictures, and I don't know if they're going to show really well out in the light. This was a young mom who just delivered a baby. This was Sierra Leone, and this was shortly before she passed away. And this particular woman had this was a healthy baby. It died. It delivered 8 hours earlier, and she bled to death. This one here is another mommy who had delivered earlier. She's 28, and she was brought there having convulsions and eclampsia, and she died shortly after the picture was taken. When you're talking about a place where family members have to go out and try to buy blood products on the street, when you're talking about medications not being readily available, you can see why the death rate is so high, with lack of facilities and equipment to take care of people when they become high risk. But we are here. Yes, ma'am.
And also, I think the major problem is the fact that they do not do screening.
They do not what?
Screen, the prenatal.
There's not prenatal care
yeah.
available?
Yeah, and just go into this time. So even if it's like, for example, the preeclampsia, maybe it could have been,
They could have headed it off, they could have treated her if they knew she had it, and they don't,
yeah.
until it's too late. Very, very sad. We are fortunate in that we do have medical facilities to deal with the emergencies when they arise. And with postpartum hemorrhage, the faster you can get it treated, the better chance you have of saving the woman's life. Whenever I hear patients say that it's safer to have a cesarean than go through labor, it makes me sad because it is so not the truth. Yes, if you start hemorrhaging during the cesarean, we can do things to save your life. We can hang blood, we can tie off bleeders, and if all else fails, we can do a hysterectomy. But it doesn't mean that it was a safer route. It is always the riskier route. And I was very excited one day in this last clinical period when a physician was talking to a patient and told her that it's always more risky to have a cesarean. I was like, whoa. Because so many times it seems that that isn't the side that's presented to patients. Yes, ma'am.
I have a patient that was, her profession, she's a model actress.
Uh-huh.
So she was totally against it. Like, she was having, she had a flu, but she seems to not be working for her.
Okay.
And the doctor for like an hour before the doctor was like, I really think get this. So after the book,
Did she deliver vaginally?
she did, but
Good
they
for
had
her.
to do a new epidural on her.
Mhm.
She had to have hysterectomy. And all this, but finally she.
Those things get better.
Yeah, she did it, but the doctor was pushing, like, we shouldn't see that. I can't do it, like, just leave
Was
it
the
where
baby
it
in
was.
trouble?
The baby was in trouble. And the baby, they never healthy. So.
I understand medical people pushing for a cesarean birth when the baby's in trouble. I get that. But I have a hard time for pushing to do an operation because the patient's tired or because of timing or any other reason.
Yeah, it's because
Unfortunately,
she's
they're not
not feeling anything. Keep telling her to push, and sometimes she use Kegel exercises and pushing. I can't feel anything.
It's hard to push. That's why one of those risk things for a prolonged labor is not being able to push effectively. What's an operative delivery? Is it a cesarean? An operative delivery is using a vacuum extractor or it's using forceps. So when you use those mechanized kinds of things, forceps by themselves are pretty big tools that go inside the vagina, and it's possible that vaginal tissues can be torn. Forceps are wonderful tools in the hands of providers that know how to use them well. Unfortunately, the younger generation of OB doctors didn't grow up learning to use forceps, so many of them are not comfortable with them, but they've learned to use vacuum extractors. You don't see the atypically attached placenta very often. Someone who's had previous uterine surgery, and if there can be bleeding or a rupture from where that scar was. And we talked about, I know in your labor class, about two different kinds of episiotomies. One's more likely to bleed than the other. So what are the two types of episiotomies? Okay, Sarah drew it. It's straight up and down, which is a median, or it's off to the side, which goes into the thicker tissues and the blood vessels of the buttocks, and that's called a medial lateral. So with the medial lateral, there's more likely to be bleeding into the tissues or bleeding while the doctor's trying to do the repair. What's considered normal for a vaginal birth in terms of blood loss?
500.
Up to 500, and how much for a cesarean birth? Up to 1,000. Most of postpartum hemorrhages are early, and most of them are still on the delivery table, which if you're going to have a hemorrhage is a good place to do it because you've got all hands on deck, you've got lots of people that can help do what needs to be done. Anything in the first 24 hours is considered to be early. So the patient might already be on mother baby, and it gets a little tougher the further you are from all your emergency equipment and people. And these are some of the reasons, and we'll talk about them individually. And then there's the one that occurs after the patient goes home goes home. And it's usually because a little bit of the placenta, it can be very small, little piece of that placenta tissue is retained, still in the uterus, and that can cause a late hemorrhage, or an infection of the uterus called endometritis can too. So our first problem with hemorrhage is when the uterus will contract down. We want a uterus that's hard as a rock. We don't want it to be what we call boggy. And when it's boggy, then you have either an atony or a very relaxed uterus. Absence of toning tone. So there's no tone, it's just relaxed. And things that are predisposing the uterus to get overstretched make it more likely for uterine atony. So your mommy who is having those multiples, or who has a really big baby, or who has extra fluid, that lady is more at risk to have a postpartum hemorrhage. That woman who had 7 pregnancies earlier and delivered 6 children, her uterus is likely to be tireder, and it's going to take more to make that uterus contract. Hopefully she's breastfeeding, and she also may need medications that are going to help her uterus contract down. Under the medications that we associate with someone who has poor tone, we have our drugs that we use to relax the uterus. First one is magsulfate. And you talked about magsulfate as a drug to help prevent seizures. It relaxes smooth muscle, the blood vessels, correct? It also relaxes the uterus. That's why it's also been used as a preterm labor drug, which we'll talk about next week. So if the patient has been on magsulfate for pregnancy-induced hypertension,